Hello, everyone. Welcome. This is the last in our winter quarter spring lecture series. My name is Barbara Cochran. I'm the director of the DeTournier Center. I'm also associate director for the Northwest Geriatric Workforce Enhancement Center, which is sponsoring this lecture series. And as I said, this is the last in the winter quarter, but we're going to be starting up another lecture series in spring. The first date is March 29th, same day each week, same time each week. And if you haven't contacted our offices, you can do so at nwgwec@uw.edu to make sure that you're on as a site for this series. The spring series is going to be focused on Alzheimer's disease and related dementia. And so just to give you a little bit of background on the presentations that are set up. They include some updates as well as some new presentations. Dementia, differential diagnosis of dementia, delirium, and depression, an update on Parkinson's disease with a focus on treatment options, riding the roller coaster, enhancing quality of life in dementia, managing ethical dilemmas and moral distress, caring for the caregiver, essentials of advanced care planning, dementia and multiple chronic conditions, driving and dementia, and putting it all together. So hope you're as excited as we are about this series, and the best is always to come, and that's Peggy Odegard. Peggy is earned her Doctor of Pharmacy degree from the University of Washington in 1990 and her BS in Pharmacy from UW in 85. She's currently professor and associate dean in the School of Pharmacy, where her teaching and research emphasizes diabetes prevention and care, with a focus on the needs of older adults. She practices pharmacy in an interdisciplinary diabetes care clinic, provides community-based education on aging to older adults, and she's a certified diabetes educator. Before her position with the University of Washington, she worked in a community-based health system with responsibility for clinical pharmacy services. I think you'll find her just an excellent lecturer and with incredible expertise. So welcome.
Yeah, thank you. So thank you for having me today, and thank you to all of those of you in the room and those of you in the joining audiences around the area or region. I'm really excited today to be able to talk to you about diabetes in older adults. It's a really important condition. I'm sure we've all either seen this in the patients that we serve and support, or we may be experiencing it, or we may have a family member with it. So hopefully I can help you in learning more about kind of the full approach to care of the diabetes of the person with diabetes who's older. Some of the key learning that I'd like you to hopefully take away from today is a better understanding of why older adults have a greater risk of especially type 2 diabetes. That diabetes, type 2 diabetes can be prevented quite well in older adults. And if we aren't preventing it, we can at least reduce the progression to type 2 diabetes. We'll talk about the goals of control for diabetes in older adults and really think about how to individualize these. As we know, older adults are a very heterogeneous population, some very frail, some very healthy. And so we really have to approach our care goals for patients with diabetes very individually as people age. We'll also look at the big picture when supporting someone with diabetes. There are a lot of things occurring with aging that may or may not be related to diabetes, including things like the geriatric syndromes, social and financial support systems. And so really kind of stepping back and looking at that big picture is really critical when caring for an older adult with diabetes. And then with regard to treatment, thinking about some of the kind of special impacts of aging on our choice and how we monitor certain treatments of diabetes, and also how those treatments might impact the older adult more specifically in some ways than they would a younger adult, are really important considerations when we're choosing therapies, specifically pharmacotherapy. So we'll talk about that. So I thought it would be helpful for us to keep in mind a case patient, and this is a patient that I had worked with. His name is Joseph. He's a 75-year-old man diagnosed, we're going to say today, as when I saw him it had been today, with type 2 diabetes. You can see his other medical conditions listed on your handout, and they include hypertension, hyperlipidemia, neuropathy, chronic renal insufficiency, mild cognitive impairment, GERD, and constipation. His weight is 186. He's 5'9", He reports a diet that includes breakfast, lunch, and dinner, but a rather kind of regular intake. He drinks 1 to 2 glasses of red wine daily. He actually heard that was healthy for him, and so he's trying to add that as part of his health plan. He does not exercise regularly, except for occasional walking about once a month. He lives alone. He's been widowed times 9 years, and he has 2 adult children who live out of state. His labs are listed here, and significant ones are his serum creatinine is up a bit, his A1C is up, fasting glucose is elevated, and his PHQ-9, or his depression screen, is scoring a bit on the higher side. And you can see his medications are listed there. He has 10 medications, of which 7 he relies on taking every day or multiple times a day to help manage the conditions that he has. So let's keep Joseph in mind. We're going to come back to him a couple times to think about goals for control and kind of what his unique needs are. But as far as diabetes and aging, I think it's really important if you know, when we think about the populations that we support, to realize that in our population that's aging, especially after 65, the prevalence of diabetes really starts climbing as you move out of your 40s and 50s and move into the 6th decade of life. And this is all diagnosed diabetes. And I think a really important mention is we'll talk about some reasons why type 2 diabetes prevalence increases with age, but we also need to remember that type 1 diabetes, which in the full 100% prevalence of diabetes, type 1 diabetes is just about 5 to 10% of the patients that have diabetes, with type 2 diabetes being by far the most prevalent at about 90% of that population. Type 1 diabetes, we have really good treatments and monitoring for now. So people are living healthy lives. They're living to be much older. And we have more and more patients crossing the age of 65 into the Medicare age with type 1 diabetes. And you can imagine that the Medicare system was not set up to support people with multiple insulin injections a day, multiple finger sticks a day to monitor glucose, for insulin pumps or sensors, or all the things that we use to support type 1 diabetes, which is where the pancreas no longer makes insulin. So we need to fully provide it mimicking physiologic insulin. So also keep in mind that that type 1 population is a population that we have to care for kind of carefully as we're seeing our older adults, if we see patients with type 1 diabetes, to make sure they have the supports in place financially, socially, and medically to help manage diabetes. Barb, it kind of went offline and then it came back. How do I? It's not wanting to move. Let me try pressing it again. Do I need to hit sync? Sorry, everyone. We went offline for a minute here.
So you're doing that, and it's not, okay.
It's not advancing. It said it went offline and then it came back online, so I'm not sure. Okay. Alrighty, thank you. So in type 2 diabetes, to think about why the prevalence of diabetes goes up as we age, because it's a potential risk factor for all of us who are aging, and I'm assuming right now we're all aging while we're sitting through this seminar. But there are several things that happen as we age that are similar for all individuals, whether you're a younger adult, middle-aged adult, or an older adult. And that is, if we're less active, we have a greater likelihood of having insulin resistance, and that lower activity level can also affect how we process the glucose that our bodies take in. But as we age, those factors are occurring, but we also are having an aging of our pancreas. And as the pancreas ages, it does not put out quite the same amount of insulin, especially with our meals, as it used to when we were younger. So the normal healthy pancreas puts out a little bit of insulin all day long to meet your background needs for glucose management. And then when you eat meals, including snacks or anything with caloric value, your pancreas puts out kind of a little squirt that's an appropriate dose to match what you're eating. As we age, especially that little squirt that comes out with meals might not be quite in proportion to the meal that we took in. Some studies that have looked at that And the slide posted here is looking at individuals with normal glucose tolerance. So these were people without diabetes. And they looked at a population, a very small population, but a population ranging from age 20 to 70. And what it showed is that beta cell function, and your beta cells are what make your insulin, declines about a little over 1% per year after the age of 20. And the first phase of insulin, which is kind of just the general phase that comes out after we eat, and then a second phase that's sort of a cleanup phase after we eat, are in particular affected, but not to a real strong extent. In IGT, or impaired glucose tolerance, so these are people who have sort of pre-diabetes, we see that as they age, the first phase of insulin secretion is specifically affected. Beta cell function is reduced with aging when compared to people who don't have diabetes. And so the kind of the independent effect of aging is that your insulin secretion is lowered or reduced in proportion to what you eat. But in particular, if you have prediabetes or diabetes, it's even more accentuated. And that's kind of that's a really unique thing with aging. So in particular, when people age, they have a reduced chance, they have greater insulin resistance, often have lower physical activity, and depending on other medical conditions, that can also impair physical activity. And then they may also have changes in how their body is meeting their own insulin needs to manage glucose. Okay, Barb, I have to tell you the screen went blank here. Should I just keep talking and then we'll catch up? Alrighty, so after after that slide, I'm on to the slide on diabetes prevention. And I think the important message here is, I was asked to talk about diabetes in older adults, but as you heard, I'm also a diabetes preventionist. And I think after many, many years of working in diabetes care, I thought there has to be a better way, and if we could move to the end of trying to prevent it, it may be very helpful. And so what I have on your slide here is the diabetes risk assessment test for type 2 diabetes. And in the 1990s, you're seeing the slides? Okay. Okay, good. So with regard to diabetes prevention, we learned, I'm very flexible, we learned through a multi-center trial that was held in the 1990s called the Diabetes Prevention Program that we can probably prevent the progression to type 2 diabetes if we work hard, especially on lifestyle management. The Diabetes Prevention Program study, thank you, John, was a large trial of about 3,300 or 3,400 patients. It was a randomized controlled trial, multi-center, and it actually looked at randomizing patients to an intensive lifestyle intervention where they worked on losing at least 7% of their body weight and being active at a moderate level 150 minutes a week. They randomized people in the next group to just usual lifestyle support with information about the importance of lifestyle and diabetes. And then they randomized people to a group that had the usual care plus metformin, which is a medication used to treat type 2 diabetes. And what they found in the analysis is that the lifestyle intervention, the intensive lifestyle intervention, 7% weight loss and 150 minutes of physical activity at the moderate level weekly, reduced the risk of progressing to type 2 diabetes 58%. Interestingly, in the metformin group, the risk reduction was 31%. So a medication was not nearly as effective as lifestyle modification. Really interestingly, to people like all of us who work to support older adults, the group that was 65 and older had the best results with a 71% risk reduction in the intensive lifestyle intervention. So the older adults that participated in the diabetes prevention program did very, very well with increasing their physical activity and reducing their weight in a modest amount. And that really had a significant impact on preventing progression to diabetes. What they did 10 years later in a study called the DPOP trial is they evaluated how did the people do who were in these different groups as we followed them long-term for 10 years. And what they found is there was actually a legacy effect of the lifestyle intervention. So even if you had gone back to your old lifestyle, you still, after having that long-term period of intensive lifestyle modification, had a reduced progression to type 2 diabetes. So it works, and I encourage us to think about lifestyle modification and ways we can support people with risk factors for type 2 diabetes, especially those who are older. This is the population we work with, and it is a really effective intervention to suggest increasing their physical activity, and the goal would be 150 minutes weekly spread out over as many days as possible. So, like 30 minutes 5 days a week, or 20 minutes, 7 days a week or so. And then a 7% weight reduction if they're overweight. Certainly if we're working with older adults who are not overweight, we don't want them losing weight. But if they're overweight, a mild weight reduction can really reduce their risk of progressing to type 2 diabetes. And if you have more questions about the diabetes prevention program, or want to learn about some great tools to help patients, or even become more trained on the lifestyle coaching to help people prevent diabetes, I encourage you to look at the CDC website. You can just, on a Google or Bing search, put in NDPP for National Diabetes Prevention Program, and there's a lot of information available. And that National Diabetes Prevention Program is listed on this slide, and the website is down at the bottom, kind of in the white print on the right side there. So prevention is important, but if people do have type 2 diabetes as they're older, there are a lot of things for us to consider. And the ADA, or American Diabetes Association, this year, and I included this as a suggested reading. It's out of the American Diabetes Association clinical practice guidelines that are published online at diabetes.org. But the supplement on older adults is just a couple of pages long. So it's an easy read if you're a busy person and you still want to get the distilled information on what are the areas I should really focus in on to support the people I work with. And I've summarized the core recommendations here, and I won't read them all, but I will. Let me emphasize a few points. One is that with an older adult with diabetes, as we all know in the work we do, we have to really consider the big picture. And so they encourage us over and over and over to think about the financial implications, especially of the treatments. Some of them are very expensive. Some of the newer treatments are $300 a month. Many aren't covered by the Medicare prescription drug plans. The insulins now, if they aren't covered by your insurance, are $500 a month. It's a great medication, but if someone needs it, we need to take the extra step to find out which ones are covered and at which costs, and how can I get these most affordably for the patient. Mental health and diabetes is a big consideration. The risk of depression with diabetes is, much higher than for people who don't have diabetes. So really important to screen for depression. We also often are working with individuals who have other geriatric syndromes, painful conditions, risk of falls, other factors going on that we need to consider, and kind of take that into consideration when you're considering the treatment. Some treatments need manipulation with good dexterity, and if people don't have that, we need to reconsider how can we have them best use this treatment. Hypoglycemia. Hypoglycemia is something I'd really like you to take away today as a risk factor, a risk we need to avoid. Hypoglycemia is, if it occurs, is dangerous. It can result in death, but it's also been now related to dementia, and especially severe hypoglycemia. I think we've all known when you have hypoglycemia or low blood sugar that you don't think as clearly, but we now know it's not just the acute cognitive impairment, but it's associated with certain forms of dementia. So avoiding hypoglycemia is really important. What does that mean for treatment? It means as life goes on, we need to consider how this treatment is posing risks for hypoglycemia and be willing to relax therapy a bit, back off on doses a bit if we're seeing symptomatic hypoglycemia. Some other things that we want to think about is depression screening. We talked about that's a big risk, and so making sure that we're regularly screening for depression. We need to think about if we have, I don't know if you have patients you see in long-term care, but in long-term care situations, we need to make sure there's support so that hypoglycemia can be monitored and recognized and treated, that patients get the support they need with taking their medications if they're not on a MedAssist program or an assisted living. So several considerations, and you can read them all here. And I'll as we work through Joseph's case, we'll also look at kind of the treatment goals and how we modify those. So in general, this is a slide pulled from the ADA 2015 guidelines, which are still backing what we're saying in 2016. But some of the take-home points here is that for an older adult who is otherwise highly functional, cognitively intact, and expected to live long enough to reap the benefits of the treatments that we're prescribing, they should really have the same treatment goals and plan approach as a younger adult. But we may need to relax glycemic targets for older adults who are more frail, who have cognitive impairment, have greater risks for hypoglycemia. And with all of our approach being, we want to avoid, though, hyperglycemic complications so that we don't risk creating problems with uncontrolled hyperglycemia. So it's kind of a fine line that we're balancing between hypoglycemia and hyperglycemia with aging. We want to manage cardiovascular risk factors. Type 2 diabetes increases the risk of a heart attack or stroke 2 to 4 times if it's left uncontrolled. And since with aging we're talking control that has to balance between not causing low blood sugars but not allowing for high, ongoing high blood sugars, we're kind of in this fine line zone of really trying to manage heart and brain health. And as patients have an increased medication burden, we really need to reflect on if they're on 3 medicines to control their glucose, but their glucose goals are maybe tighter than what we need, and now they really need to start something to protect their heart, like a statin or something. We may have to actually back off on our glucose management so that we can enhance their cardiovascular protection if you just can't keep adding medications. And ideally, we should be doing that in all age groups where we reflect every time we add a treatment to see, do we really need to add this or can we get a twofer by substituting it with something else? But I think in aging, it's particularly, we need to be particularly sensitive because as the treatment burden increases, we have problems with hyperglycemia simply because patients can't adhere to the treatment regimen. So the American Diabetes Association a few years ago put together an expert group to really think through all the data that was out there in the literature from studies, looking at just all areas, including depression, pharmacotherapy, social supports, long-term care, everything, and look at what does this data tell us about the goals for control and how we should be kind of organizing ourselves to support someone with diabetes. And this table was published from a consensus report that came out in 2012, and the citation is noted at the bottom of the table. And it was updated this year in this guideline, the 2016 guidelines, a bit. And I'll show you where that was updated. And on this table, I think that the interesting thing you'll find, okay, well, we won't use the pointer. But I'm clicking on the pointer and it's, there we go. Okay, so if you look at, the table is trying to divide the population into 3 general groups. One is an older adult who's otherwise healthy. And what that means is they have few coexisting chronic conditions, they're cognitively intact, and they have very good status. Then the second category is kind of a complex intermediate health situation, and that might be someone with a high treatment burden, with mild cognitive or moderate cognitive impairment, or some impact on their activities of daily living. And then the third category is down here is very complex or poor health, and that would be an individual with limited life expectancy, who's very frail, that you don't believe the treatment benefit, the time to treatment benefit will be realized versus the treatment burden that the treatment might pose. And so you can see that this list now organizes a whole different A1C approach than what we're used to. So where the American Diabetes Association goal for A1C in a person who's younger is less than 7%, we've now in the 65 and older age group, based on the data, realized that going to less than 7% may have more risks of hypoglycemia than benefit. And what the data shows is that a reasonable A1C goal for an otherwise healthy older adult is less than 7.5%. For someone who's in complex or intermediate health situation, we go for less than 8%. And someone who's very frail, The goal was chosen as less than 8.5%. And what that is balanced against is if you go above that, you start getting symptomatic hyperglycemia. But to go below that, you start adding treatment burden, and you may not realize the benefits of that treatment in the time they have in their life. And so that I think is probably the most controversial new goal that came out over the last few years. And I will tell you, working with older adults in diabetes, some of whom who are very dedicated to controlling their diabetes and have done a phenomenal job, it is a difficult conversation to have with someone when you see they're starting to have symptoms of their treatment, that they now, maybe they've controlled their glucose to less than 7, maybe it's actually like 6.2% A1C, and you're seeing they're having hypoglycemia, and you know that's a risk factor, especially for increasing risk for dementia. To have that conversation with them about now relaxing some of their treatment to raise that goal a bit. You know, I've had patients say to me, what? I was told for years to get less than 7. Now you're telling me I don't have to do this. And so really kind of thinking, I think, proactively about how you'll have that conversation. And what I usually let people know is that, yes, less than 7% was a perfect goal when they were younger. But as they're getting older, we know that the benefit of having it less than 7 may be outweighed by the risk, and that backing off a bit can prevent hypoglycemia, which could have risks to their cognition, and that we don't want to harm that at all. So reassuring them that their heart health and the long-term complications risk is still low with going with this 7.5% goal or less, but that we're trying to kind of balance out risks on the other end. You can also see from this table that the fasting, what was done is the fasting glucose goals that correspond to those A1Cs were outlined for us, and the bedtime glucose goals that correspond to those A1Cs were outlined for us. And then the blood pressure goals, that is the main update, and I put an asterisk there to alert you, and it's updated in the reading I gave you. The blood pressure goal as of this year for older adults with diabetes is less than 140 over less than 90. The data just doesn't show a real benefit of pushing it down farther. If you can, that's great. And those of us who work in this area know the old goal was less than 130 over 80. This group came out and recommended 140 over 80. But now overall, for older adults, they're recommending less than 140 over 90. And then use of a statin to reduce other cardiovascular-related risks of diabetes is indicated in those who are healthy or with complex health, unless there's a contraindication, but in those with very poor health to really consider the benefit. Those of us who've seen them used in patients know that they can sometimes cause some side effects like muscle pain that creates some morbidity for the patient, and so really thinking about the benefit is critical. And in general, treating blood pressure and lipids, you actually can achieve the benefit if you look at the long-term studies within about 3 to 4 years. Blood pressure is a little bit earlier. Lipids is more the 4-year mark. You have to manage glucose for about 7 to 8 years to really start seeing the benefits of preventing those chronic complications. So you can see why, as people age, sometimes we shift our focus to be more on blood pressure and lipids because the cardiovascular risk is so high in people with type 2 diabetes. So I recommend kind of keeping that table, printing out a one-page slide of it, because it's a great pocket reference, or if you have printed out this 2-page update from the ADA, it's in there also. So with diabetes, we have several considerations then as people are aging. And I think you're seeing it's a picture that makes it for great team care, because there's a lot of factors that need to be considered. And I think as a clinician, no one person can really support all this on their own. So recruiting your supports and figuring out, including the family and the patient as part of the team, I think is important. From a physiologic standpoint, just as a bit of a review, we're focusing a lot more in aging on the postprandial hyperglycemia because we know they're not making enough insulin with their meals. So just to give you a heads up, if you're seeing they're not gaining good glucose control and their fasting glucoses look fine, which is often the thing we're really monitoring, you might look at a postprandial at 2 hours and see, are they having problems with their meals? Is that's what escalating their glucose levels and keeping their diabetes out of control? Because sometimes some treatments will focus more on that, and you can aim at that. And one of the treatments that focuses more on that is watching what we eat. And another one is physical activity will also sometimes help us process what we eat a little bit more. There is an increased risk of hypoglycemia, so staying away from treatments that are more prone to cause that until they're really needed is important. There are some age-related pharmacokinetic, I'm a pharmacist, so I have to talk about this, but there are some age-related pharmacokinetic and pharmacodynamic changes in the body. The most profound being our kidneys are also aging, and kidney function, as measured by like a glomerular filtration rate, goes down about 1% per year after age 50. So even if you can't measure kidney function or see a laboratory result, if you're working with an 80-year-old and they're on the same dose of something they were on at 50, you can imagine they might have 30% reduced clearance of it if it goes out through their kidneys. And so you will see in older adults now, and we don't have specific guidelines on this, but you will see in this clinical practice recommendation some recommendations to consider reducing doses of things like metformin, because something like 1,500 milligrams of metformin with kidneys that aren't functioning as well may be the equivalent to that body of a bigger dose if their kidneys were working well. So you'll see a little bit more recommendation on avoiding medications that rely kind of on the kidneys to be working well. In particular, and we'll talk about it more in a couple of slides ahead, is some of the sulfonylureas like glyburide is cleared out through the kidneys, and it has an active metabolite that's cleared out through the kidneys. So if people are on it and their kidneys aren't working well, they're really at risk for a low blood sugar. So that one is now contraindicated in older adults. Self-management is a big issue that we need to make sure we assess. And I'm just honest with people. I just say you have a lot of medications here. You have a lot you're doing to manage to watch your meals, to prick your fingers, to get activity, all these things you're doing. What is the most challenging, or is there anything you feel that you're really having difficulty managing? And I usually tell them, any answer is okay. I'm here to help you, so any answer is okay. Because sometimes they'll say, I can't do any of it. I don't take any of my meds. And I want to know that because I think making sure what their competing priorities are and managing within that is important. Their environment is important. If they shift from maybe being more isolated where they can't access food as well to assisted living where they're getting regular meals, their needs may change for their diabetes management. Or on the flip side, if they're getting regular meals or maybe have a spouse who cooks for them and they lose that partner and now they're not getting regular meals, they might have the opposite and a risk for hypoglycemia from the treatments. And then we talked about that fine line of managing the diabetes to avoid hypoglycemia but not allowing hyperglycemia to occur, so kind of staying right in the middle there. And we also talked about thinking about treatments from the context of, is this person going to benefit from the treatment? Do they have the time in their lifespan to benefit from the treatment? And if not, it's not really worth starting a treatment sometimes. But we want to keep them as healthy as we can with their diabetes. So here, just drilling into a few of these specific things, cognitive impairment in diabetes is a big factor of consideration with aging. Obviously, cognitive impairment can also impact their ability to adhere to a regimen, so needs to be considered and they might need support. As a pharmacist, and I know there are some pharmacists in the audience, I think it's also important to think of your pharmacist colleagues with regard to cognitive impairment and support with medication management. Some pharmacies have medication management programs. There's MediSets. There's if they're using insulin, there's certain ways they can help people with insulin to better manage that. So kind of thinking about the pharmacist colleagues on the teams to help with cognitive impairment that may be getting in the way of being able to effectively manage. The other is our social work colleagues to be able to help us with caregiver support or other in-home support if people need that. Again, I think it's really we need to remember a team approach to diabetes care, including the family and the patient, are really important. So there's a lot of complex interactions going on in older adults with type 2 diabetes. I say this to you not to overwhelm you, but to also, I think it actually makes it really kind of an interesting area to work in, to really pull on all the things you've learned and pull in different teammates and make sure we're providing the support we need. With type 2 diabetes, we can see on this graphic that we have increased morbidity, increased mortality if it's left uncontrolled. But on the flip side, because of the geriatric syndromes like risk of falls, physical disabilities, and then some of the diabetes complications that from uncontrolled diabetes, like retinopathy or nephropathies, we don't want to get in a place where the diabetes is creating more disability than we need it to. So kind of balancing treatment against outcomes we're trying to achieve and maintaining quality of life is kind of the main balance that we're trying to achieve. Older adults do have the highest rate of complications of diabetes. So we need to be sensitive to the fact that to avoid hypoglycemia, we don't want to err towards continued uncontrolled hyperglycemia. Again, looking at that chart that we put out is a really important guide to help you know how much is too much and how low can you go. So thinking of that less than 7.5% A1C, less than 8%, or less than 8.5% A1C, depending on the patient. Older adults also have increased rate of ER visits due to hypoglycemia. They're much more sensitive to hypoglycemia for several reasons. Sometimes they're on medications that are causing it. They also have an aging system that responds to it. So our adrenaline system is the first system that helps alert us of a low blood sugar. And that adrenaline system may not work as well as, kind of the aging of the beta receptors. And so when we were younger, if we had a low blood sugar, we may have gotten really shaky and anxious and realized I need to get some food. You might not quite feel that when you're older. And the studies show that actually it's quite a significant point in glucose drop before an older adult will feel the same level of they have to go much more low before they feel it than a younger adult. So our kind of alert system for recognizing hypoglycemia changes quite a bit with aging. The geriatric syndromes are really tied up with diabetes. Gait problems and falls is an issue in aging as a geriatric syndrome, but people with uncontrolled diabetes may have neuropathies that contribute to gait problems and falls. So really trying to avoid that and help manage that within other gait problems or fall risks that they have. Polypharmacy is actually, as we know, it's a geriatric syndrome, and we can make that worse in caring for diabetes. So really trying to approach diabetes care, not worsening polypharmacy, is important. We've talked about cognitive impairment and depression, and just to highlight the importance of really thinking about vision and hearing impairment and being able to manage diabetes, making sure we have clear written instructions and verbal if people can't, so that they can clearly get the directions. Barb, I have a hand raised here. I had a hand raised. Okay. Okay. Okay, that's okay. So back to our case, Joseph. And if you remember, he was a 75-year-old man, just diagnosed today with type 2 diabetes. If you remember some things about him, he had a lot of conditions, including hypertension, hyperlipidemia, GERD, constipation, neuropathy, mild cognitive impairment. I think I got all of them. And then we talked about some of the other data they're listed on him. He has 10 medications, 7 of them are routine medications. So reflect on this slide and consider what you think would be the appropriate A1C goal for Joseph. Okay. So we'll talk about it a bit more at the end, but if you recall, 6.5% wasn't on the list, and that actually is a goal, though, that's recommended by the American Association of Clinical Endocrinologists for otherwise healthy adults with diabetes, so not necessarily speaking to the older adult range. Less than 7% is the ADA kind of standard for their goals for control for adults with type 2 diabetes or adults with diabetes. Less than 7.5% was on that grid as a goal for adults who otherwise are healthy without cognitive impairment, and less than 8% was the goal for adults with intermediate or complex health with factors including changes in ADLs and mild to moderate cognitive impairment. So if you got less than 8%, that is an acceptable answer. If you got less than 7.5%, some would feel comfortable with that. But since he does have mild cognitive impairment, you might want to know more about that. But either 3 or 4 is probably the right answer. And I work in this area, and it's still a leap for me to go for number 4 because I focused on less than 7 for so many years. But that would be the expert recommendation right now based on the data. So one of the tools that is published, and I listed the reference that goes with this at the last slide to help you out. It's actually a really good article on management of type 2 diabetes. But what I like about this is they have this kind of slider approach to consider, so that if you look at this and look at so the patient's attitude and expected treatment effort, you kind of ping that on the scale, and you go down the list to come up with, am I trying to have more stringent control or less stringent? And you'll see with aging, we're talking the first factor may be affected if patients have a high treatment burden already from other conditions, and they're like, I just can't add a lot more to do. They also have risk for hypoglycemia, so we might be erring more towards the less stringent goal if we're worried about that risk. They may have new disease, or they may have long-standing type 2 diabetes that now they've kind of lost control, or maybe they've never gained it. And anytime someone has long-standing diabetes, you need to go more to the less stringent end of control, because we know that controlling them down too tightly or too quickly to that goal has a risk to their heart of a heart attack. Life expectancy, if it's a short life expectancy, we would go again with less stringent goals. Comorbidities, vascular complications, and their support system and resources. So you can see every factor on this list applies to what we consider in supporting the older adults we care for. So I think it's a really helpful tool to kind of get comfortable in your mind with, are we trying to control this more tightly, or for lack of a better term, I'll say more loosely, kind of keep them healthy and comfortable, but not necessarily try and really drill down to tight control. So what would be the initial approach to improve glucose control in Joseph? Think about, would you want to increase his physical activity? Would you want him to reduce his weight? I think he was 186 pounds and 5'9". Would you want to start metformin, or would you expect that whoever's going to be prescribing might start metformin? Would you do all of that? Or would you do none of it and think he's going to need insulin because she told me that he might not be secreting enough insulin anymore? So think about your answer for that. This would have been great for like a audience poll. Yeah. So the acceptable, what's that? Not today. We have enough technologic things going on here. So the answer I was looking for is all of the above. And some key take-homes I wanted to make is, even though Joseph already has type 2 diabetes, those diabetes prevention strategies we talked about, weight loss if he's overweight, and increasing physical activity to 150 minutes weekly, that's again the goal, that might not be where he starts. Those are both have been shown to be effective interventions in managing diabetes. So even though they're prevention strategies, they have been shown to be very effective and helpful in type 2 diabetes management. And actually that both of those are effective management strategies with hypertension. So he can get a 2 for on that. So increasing his physical activity, again, you have to help meet the patient where they're at and suggest they move it up a notch. So if he, as we learned, is walking just once a month, I'm not going to ask him to go out and start walking every day, especially if he has painful neuropathy. But what I might do is help acquaint him with Sit and Be Fit, which is an exercise program on TV that you can do in a chair. I might see if he likes, if there is an activity group, like a swimming group or something like that, that he wants to join, that could be a healthy activity. But even just helping people look at what they're doing and taking it up a notch to be a bit more active is really helpful. If he's very, very sedentary, even suggesting things like getting up and walking around his kitchen or his up and down his hallway every hour or something, just slowly, is going to increase his activity level. It may not have those big cardiovascular benefits that you might need moderate level physical activity to have, but it certainly will help his glucose, and that's what we're looking for here. Reducing his weight could be helpful, and it does not have to be. The study actually looked at 5 to 10% weight loss. The diabetes prevention program honed in on the 7%, but a 5 to 10% weight loss can significantly reduce blood glucose, so that can be helpful. And then metformin is by far the #1 drug we recommend in type 2 diabetes, even in older adults who we know are having a little less insulin production. The reason why is it matches up well with one of the primary factors that's derailed in type 2 diabetes, and that is that people have become insulin resistant, and their bodies often like to make more glucose than they should. So if you think about it, our livers store glucose in the form of glycogen. They save it for a rainy day. If we're caught in the middle of a desert and we're on a desert island, we don't have food, our bodies can help with breaking some glycogen down into glucose. For someone with type 2 diabetes, we know they tend to produce or break down a lot of glycogen and make it into glucose. They're producing a lot of glucose in their body. That is particular. How do you know that's happening? If someone has high fasting glucose levels, but they're normal throughout the rest of the day, that's a signal that at night they're sitting there and their liver's pumping out glucose. And we know that in type 2 diabetes, that's kind of characteristic. So metformin matches up really well because it helps modify insulin resistance, so your body uses its own insulin, is more sensitive to it. It tells the system that's making glucose in the liver to knock it off and get back on track. And then the other thing that metformin does is actually it's being demonstrated in studies to have some sort of cardiovascular benefit. And so we're now more than not trying to make sure people can stay on their metformin. The trick with metformin is, again, as I mentioned earlier, it goes out through the kidneys. And we know that if you hold on to it, you may have a greater risk of a bad side effect called lactic acidosis. And so just being sensitive to kidney function is something, and the patients you work with, they will have a blood test that measures how well their kidneys and liver are working before they start it, so that the prescriber can assure that they will be able to clear out any extra of the medicine and that they won't have that risk. But if that person or that patient is faced with a situation that might affect their kidney function, like their heart failure worsens, or they go in for a contrast media procedure, or they're admitted for a surgery, they will likely stop the drug so to avoid any risk with changes in kidney function. And then when kidney function gets to the GFR level of 30 mils per minute or less, providers will stop it, because at that point we feel the risk of using metformin might be worse than the benefit of having it. But 30 mils per minute or less is pretty low. We used to cut it off much higher than that. And I think once we learned there's a cardiovascular protective benefit, that we're trying now to keep it on board as much as possible. And it works well for managing glucose in type 2 diabetes. As far as number 5, I put this in here kind of strategically. A lot of patients will ask, will I ever need insulin? And the answer is, we don't know. If they're still making plenty of insulin and the treatments we use can complement with that, their own insulin supply, they may not need insulin. But if they're not making enough insulin anymore, yes, they may need insulin, because ultimately that's what our bodies use to control blood glucose, and it's kind of the gold standard medicine. So I usually try and frame up front with people that insulin's actually a great drug. It's what your body uses. And so let's not put it way out here just to stave it off. But if we need it, your body will give us some signals, and then if we need to use it, we can use it in a way that works best for you. And in type 2 diabetes, if insulin is added, it's often added as just a once-a-day injection at the start. So you just have to take 1 shot a day. But I think he probably doesn't need insulin right now. If you remember, his A1C was 8.2%, I think, in the case. And so if our goal is to get him less than 8, he probably just with physical activity, watching what he eats, and starting metformin can easily get to that. The metformin is the oral pills for diabetes reduce your A1C at best 1 to 2%, and metformin is the one that does it the best. The others are a little less than that. Insulin can lower an A1C as much as you need it to go. So if someone has an A1C of 12 or 13 or 14%, they may need insulin to bring it down, because metformin might drop it from 14 to 12 and be very successful, but they still have very uncontrolled diabetes with a lot of risks with that. So the factors that impact treatment choice are many. And when we're thinking about medications for diabetes, I think we need to think about all these factors. But when we're also thinking about, when I say treatment, I'm speaking of nutritional, meal planning and changing what they're eating if it's not helping, if they need to kind of modify it a bit to manage their glucose. Physical activity is part of the treatment plan, and then medications are definitely part of the treatment plan. But you have to think about all of these factors, and as we've talked about a few times, in an older adult, some of these factors are really, really important that we need to consider. We should be considering with all patients with diabetes, but I think in aging, we really need to make sure they're on your checklist, including things like depression screening, their social support, their cognitive abilities. What is the other treatment burden? So remember with Joseph, he has 10 medications he takes, 7 that are prescribed daily, at least once a day, some of them twice a day. So adding a treatment is really increasing the treatment burden for him. What's the treatment time to benefit? How is his functional and physical ability to be able to use those treatments? So looking at a few of those factors we need to consider just to help kind of focus your energy around the importance of them. Depression is a big factor. So in older adults without diabetes, depression is a factor. And you can see from this graph that the risk of having depression is doubled in those with diabetes. And you can the graph is the amber bars are women and the green bars are men. So interestingly, if you have diabetes, your risk of having depression is much greater. If you have depression, your risk of having diabetes is greater. And it's sort of the chicken and the egg right now to figure out. I think about 5 years ago, we were trying to figure out, does one cause the other or does the other cause the one? And I think we now know they both can cause each other. So when you have hyperglycemia, there are effects, and we're learning now at the molecular level more specifically what they are, but effects on the neurochemistry and the risk factors for depression. But on the flip side, if you have depression, especially if self-care or eating or sleeping or factors like that are affected by your depression, you may have greater risk for diabetes. The other thing is treatment burden. We know that as it increases, your risk of poor glycemic control increases. It's kind of counterintuitive because you think that as your number of treatments increases, you might have better glycemic control, but it's actually the opposite because people sometimes fatigue and just withdraw from using certain therapies or they make choices. And so what we as the health professional team think they're using is sometimes very different than what they're actually using. So especially those of you who do home visits, it's so helpful to the rest of the people on the team if you actually can see what they're using. You know, look in the medicine cabinet, have them bring out their meds, have them tell you using open-ended questions what they're using and how they're using it, and set it up so that they trust and understand that any answer is okay, that you're just trying to gather a kind of an update on what they're using. Because when they have a lot of medications, they may start making choices, and if we can step back and say, okay, we may have actually overburdened them, and then help them make choices towards the ones that would give them the most health benefit, I think that's a helpful thing to do. The other is treatment risk. So hypoglycemia, we've talked about several times. It's a pretty big risk factor in aging, especially in people taking medications that are meant to lower blood glucose. So there are 50% higher rates of severe hypoglycemia in older adults, severe meaning requiring assistance. There's earlier and more severe deterioration of psychomotor coordination. So whereas the rest of us might need a blood sugar that we might tolerate a lowering of our blood sugar to a much lower level before we'd have kind of neuroglycopenic symptoms where we're maybe slurring our words or not making sense. In an older adult, that can occur earlier. They have impaired awareness of the warning symptoms even when they're educated about them. So they could be educated about them, but a big factor is if their body doesn't have the hormonal system that's working efficiently enough to be able to signal strongly that something's happening, When we have a low blood sugar, the first thing that should happen is your stomach should growl. And that's our parasympathetic system trying to tell us get some food. But then our sympathetic system will kick in and start sending us signals. And so you have both of these systems doing things. You may start getting clammy and sweaty. You may start getting a bit shaky. And things are happening. And for an older adult, they sometimes are very unaware those things are happening, or they may simply not be able to physically recognize that. So there's a 10 to 20 milligram plasma glucose difference between subjective awareness of hypoglycemia and the onset of cognitive changes due to low blood sugar. And there's a higher risk in those who are cognitively impaired, I think, for obvious reasons. There's predisposing factors with aging, or there's predisposing factors, and aging is one of them. But you can see several other predisposing factors listed here that may also be something an older adult is experiencing. They may have had long-term disease. They may be taking insulin. They may be using, SU is sulfonylurea, which is like the glyburide, glipizide type of drugs. They may have cognitive impairment. And then there are factors that precipitate a low blood sugar, so they help make it happen. And that includes some of the anti-diabetic agents. Other medications sometimes, like potentiators, such as ACE inhibitors, can potentiate hypoglycemia. Alcohol intake. Alcohol intake actually blocks our liver's response to rescue low blood sugar. So that, plus if you're impaired, you might not sense it. So that can be a factor. And then you can see some others listed here as potential precipitating factors. So in an older adult, you can see there's just this, it's not a double whammy or triple whammy, it's a multiple effect on risking hypoglycemia. And the big risk we worry about is studies have shown that when patients experience hypoglycemia, that the risk of cardiovascular events increases. So the heart likes a certain glucose level, and it doesn't like to be subjected to big variations. And that's why with extreme uncontrolled hyperglycemia, we run a risk of a heart attack. But on the flip side, if the blood glucose goes down really low, we know that with hypoglycemia, the rates of cardiovascular events are also up. So again, I think you're hearing a theme with type 2 diabetes. Again, big name of the game of what we're doing, is really to help protect the patient from a heart attack or a stroke. Sulfonylurea-induced hypoglycemia, I think, is worth mentioning. On the guidelines, you see metformin all over the guidelines, and then you see a hodgepodge of other drugs as the second line or third line therapies. But the reality for those of us working out in the real world, not the guidelines aren't real world, they're trying to guide the real world, but is that we still see a lot of patients on glyburide, glipizide, glimepiride, and the sulfonylureas. And so I think it's really good to know about their benefit, but also their risks. And they are interesting drugs. What they do is they essentially, you have to still be making insulin, but they essentially help the doors on the pancreas that release insulin to open up better. And interestingly, when some people just they have rusty doors as they get older, so they may be making enough insulin but not secreting enough of it. So sometimes you'll see older adults that when they go on these are exquisitely sensitive. And I worked at a geriatrics clinic for many years, and we used to say, oh, they just need a whiff of it, and they really get a profound effect. So you'll see if these medicines are used, the doses are started very low, and it's really good to know that if you're a prescriber. So it might even be a dose of glipizide as low as 2.5 milligrams or 1.25 to start. So again, thinking about, do patients have to cut tablets for their starting dose just so we can see how it works. But we know that a lot of people, 50 to 66% of patients with type 2 diabetes use sulfonylureas. So even though you don't see them listed up top on the guidelines, they've been out for many, many years, and they work. Factors that predispose patients to sulfonylurea-induced hypoglycemia are their age, because they won't clear it out as well. Their body's hanging on to more of the dose than was planned. But also, they work. And so if patients have caloric restriction or a fixed meal plan where they go and they get meals, that drug is working whether they make that meal or not. And whether they eat that full meal or not can affect, that drug is still working. So those are big risk factors. The drug, as I mentioned, that we really have to avoid any longer is glyburide. glipizide and glimepiride, if a sulfonylurea is used, is just a safer choice. They're much shorter half-life drugs, so they reside in the body less time, and they also don't rely as much on that kidney function for elimination. Glyburide, it goes out through the kidneys, and it also is converted by your liver into an active medicine that also goes out through the kidneys. So you get this kind of double effect of a risk with glyburide. So you'll see in those 2016 guidelines, it actually says glyburide is now contraindicated in aging in older adults. So some summary, to summarize the treatment considerations, and again, when I say treatment, I'm thinking the big picture, not just the drugs, but lifestyle is always a key foundation to diabetes management, type 1 or type 2 diabetes, but it's really a foundation. Movement, and I call it movement because especially with the current age of older, generation of older adults, many never thought of doing exercise. So just talking movement, and exercise can be a scary word if you haven't done it in a while, because you think, sometimes people think you're meaning I have to go to a gym or I have to buy new clothing to do this. So just talking movement, just getting more movement, physical movement is helpful. And then healthy nutrition make a difference. And what I remind my patients is healthy nutrition is important in all aspects of life. So it's not that this is a unique recommendation in diabetes, but it is an important recommendation in diabetes because it can impact the control of their diabetes. Carbohydrates, helping people understand what is a carbohydrate, and that carbohydrates are turned into sugar or glucose in your body, and that's the thing that we're talking about that we measure when we check your glucose and that we're aiming to control. Carbohydrates turn into glucose for a good reason, because they're used as energy. It's just taking in too many carbohydrates provides us with more energy than we need. So helping people kind of understand that concept and then understanding what has a carbohydrate in it. There are some real hidden sources of carbohydrate that many people don't realize. So I usually ask people, I explain to them what a carbohydrate does, and then just say, what are some of the favorite carbohydrates you like to eat? And that helps me see where they're at. They might say, well, I like candy. And then I'll say, okay, so you like candy. Do you ever eat potatoes? And sometimes people say, really, I didn't realize potatoes are a carbohydrate. And I'll say, yeah, any of the starchy foods are carbohydrates. Oh, well, I eat bread all the time. And then I'll say, how about rice? Rice is a carbohydrate? And, and then I'll say, yes, it is a carbohydrate. And then how about fruit? And usually what people say is, I thought fruit was healthy for you, And I'll say, fruit is healthy for you. And you should eat fruit if you that should be a good part of your diet. But it does raise your blood sugar. And so we just need to make sure we're thinking of all the sources of carbohydrates that you're getting in your diet and how to balance those throughout the day. So kind of helping, in your work with people, just those basic nutritional messages. Once you feel they're ready for it, a consultation with a dietitian for someone with diabetes is really helpful, so that they start fine-tuning and learning how to really make their diet the most helpful it can be for their diabetes. But just even starting with some basic understanding is helpful. I think that when people have more self-awareness, they do really well. And sometimes we forget that just basic awareness around just the foods we eat and the impact they have on glucose can be really helpful information. So consider the treatment burden. Part of that treatment burden is the cost. As I mentioned, some of the diabetes medicines are really expensive. So metformin, the sulfonylureas, those two, from a medication treatment standpoint, you can get often on the $4 prescription. So those are considered rather very low-cost treatments. But the newer agents, the ones you see advertised on TV, and just some of them are very, very good for helping manage diabetes and certainly even in helping reduce some other risk factors. But we just have to think about the costs. Many of those newer medications, I would say, range from $200 to $500 a month if they're paying out of pocket. And so that is a really important consideration. Functional status, thinking about, can they take this treatment? I mean, I have worked with people who have been referred to me with moderate dementia, and they've been asked to check their glucose 4 times a day, and they, as far as even training on how to use the meter, it never, it's not something that they could do. And so I've had to be an advocate the other way of saying, I don't think using a meter is appropriate for this person, and can we just have them come in once every 3 months for an A1C check? Or if there's someone in the home who wants to help them check periodically, that's fine. But I've also had to really help assess if that's too scary for a patient, especially someone with more advanced dementia. To have someone coming at you with a finger pricking device is rather scary and painful. So kind of, again, thinking about caregiver support and how to engage it, but also how to make sure caregivers are comfortable with a different therapeutic plan if it makes more sense for the patient. Caution for safety during transitions of care. People with diabetes are managing a lot. There's a lot going on. And when they move from home to the hospital or the hospital to the nursing home, they can easily have gaps in transitions of care. So making sure somebody's watching for the big picture of what was the plan and is the plan being continued. And if something gets stopped when they're admitted to the hospital, should it be restarted when they're back home? It's important to ask that question. A lot of times the answer is yes, but if that treatment was replaced with something else, the answer might be no. So advocating for patients and really speaking up when you're concerned there might have been a gap in a care transition. Medication treatment, just a reassurance that metformin is still a great first-line treatment for older adults with diabetes, as it is and as we see for younger adults with type 2 diabetes. For type 1 diabetes, insulin is the treatment of choice. But do consider a dose adjustment, or you may see, for those of you who don't prescribe, you may see a dose adjustment in older patients or those with reduced renal function. And I think we didn't know this for many years, and I think now we have explanations on why some of our older patients could start 500 milligrams of metformin and actually have a really good change in their glucose on it. Before, it seemed like, how could that happen? Because we were all taught that you have to get to a dose of like 1,500 milligrams a day before you really see a therapeutic effect. And once we put 2 and 2 together, that 500 milligrams to an older adult may be the equivalent of a much bigger dose if for someone who has healthy functioning kidneys, it's making sense. But we still want to titrate the dose to get the effect, but titrating up to the full dose in an older adult just probably doesn't make a lot of sense given the fact that you may run into increased risks for the side effects. Glyburide, avoiding that. So really with medications, those are kind of the two key take-homes for older adults. All of the other medications for type 2 diabetes can be considered for an older adult. I think finances is the big factor that we need to think about. And then the new SGLT2 inhibitors like Invokana and some of the newer ones that you see advertised on TV, they work on the kidneys and they help the kidneys to pee out more glucose. And so they have a side effect of causing urinary tract infections or vaginal yeast infections. And so I think that's kind of a side effect that's really unwanted in anyone. But if you're choosing therapies, I might steer away from that. The glitazones, otherwise known as the thiazolidinediones or TZDs like Avandia and Actos, those actually can cause some weight gain and fluid retention. So those tend to be contraindicated in people with heart failure. But I have seen older adults who didn't have heart failure still have a lot of fluid retention, and we don't want to put them at risk of other conditions. So I tend to stay away from those in older adults. We talked about the sulfonylureas and metformin. We talked about the value of insulin if a patient needs it. And then those new GLP-1 agonist drugs like Victoza, Byetta, and Bydureon, those are wonderful medicines for, especially for people who are overweight because they cause weight loss. There's a pretty profound weight loss that comes along with the glucose control. But so they're really not the right medicine to use for glucose control in someone who's already a low weight or ideal body weight older adult because you don't want that weight loss. So kind of keeping that in consideration. And again, those newer drugs, I haven't focused on them a lot because they're very expensive, and I think we should really go for these, like the metformin first and then move on from there carefully. So regularly assessing patients for hypoglycemia is another important consideration. I usually ask patients and their caregivers about signs and symptoms. I start with, have you experienced a low blood sugar? And I usually don't say hypoglycemia because that's kind of a medical word, so I say low blood sugar. And if they stare back at me, I'll say, have you ever been really hungry? How did you feel when you got really, really hungry? And they'll say, oh, I get, I get kind of shaky. Sometimes I get a little sweaty. I'll say, okay, have you experienced that lately? So keep defining it different ways to tease it out. But what I'm looking for is if someone's having a low blood sugar, so a true low blood sugar, like less than 70 to 80 milligrams per deciliter glucose, that they need to treat more than a couple times a week, that's a signal to me that their therapy is too tightly controlled and might need to back off on it. It may be that we've got just the right dose, but now we've mismatched it to what they're eating, or maybe their physical activity has gone up, so they're burning more of their own glucose and don't need as much of a dose. But I kind of use that 2 times a week. If they're feeling like they have hypoglycemia, but they tell me, well, my blood sugar was 200 when I checked it, and I know that maybe the treatment just worked a little too quickly and they went from 350 to 200 really quickly, and so their body sent them all these signals, but it wasn't true hypoglycemia. I won't necessarily back off on the treatment. I might actually just talk to them about the dose we have them on, what they're eating, what else they're doing, and try and help them get more comfortable with the therapy. If need be, and I think we've gone too aggressive with the dose, I will back off on it a bit with the intent that I keep increasing it more slowly to get to the right effect. But truly for people who are having those real symptomatic true hypoglycemias with a blood glucose less than 70 or 80, if they're telling me that's happening more than once or twice a week, depending on the situation, I will look at their treatment and recommend that we adjust it. So for those of you who aren't in a prescribing situation with your responsibilities, but you're seeing the patient, if you can alert the prescriber that, especially if you see people in the home, that I'm out at the home, they've actually had a couple episodes of hypoglycemia this week, and if you know the numbers, let them know. And I'm wondering if their treatment might be causing this. That is really helpful information for prescribers to be able to then enhance safety and adjust those treatments. Sometimes that doesn't get communicated back, so it's really important advocacy. Reviewing blood glucose logs is helpful if people have them, so that you can help them understand those numbers. How do I review a log? I look first for lows, so any numbers less than 70 or 80, I say, hey, you got a 51 here. What happened then? And if they say, oh, Peggy, I skipped lunch that day. I should have remembered, but my sister called and I chatted with her, or whatever. If there's a good reason, then I'm okay with it, because it was a preventable hypoglycemia that they were aware that they had something happen that caused it. If they say, I don't know what happened, I had took my usual dose, I ate my usual meals, had my usual activity, and I kept having these lows, then that's when I jump in and start looking more into what's going on. Then I also look for trends in hyperglycemia. And if you've seen glucose logs, you know they have like days, times of the day down the columns, and then days of the week in the rows, or sometimes they're reversed. But if you can look for trends to help them identify patterns, like, hey, next time you see your doctor, I'm seeing that before you go to bed, it seems like you have a lot of, that's when your numbers are higher. You might mention that to your doctor. Those are the ways you can help people by framing what's going on with them, so that when they go into medical care, they can help their doctor or their provider in being able to consider a little more specifically what might be going on. Like, my numbers tend to be high in the morning, but I've noticed they're fine the rest of the day, and that sort of thing. So I think that kind of pattern management can be really helpful for people to be able to advocate for themselves also when they go in. So what I have here, just as a resource for you, is kind of the medications. I didn't want to delve too deeply into all the medicines for diabetes in this talk, because I was trying to step back and really take a more holistic approach to all the things to think about. But you can see some of the interactions of drugs or diseases with use of these medicines, and there's a little additional information that I've included there. I lined out avoid initiating metformin in patients 80 years or older, unless GFR within normal limits, because that's been updated now, and we know that you want to carefully measure GFR, but you can use it. You just have to make sure you stop using it when you get to those lower levels. So Joseph, how can we best help him? So now hopefully you've got your wheels turning at the end of this Tuesday. So his A1C is 8.3%. His fasting glucose is 158. So I haven't talked a lot about targets, but a fasting glucose target for control would be between like 80 and 130. So he's above that target right now, but he's not too far away from it. I mentioned sometimes you can have people check a 2-hour postprandial to see if that's a bigger factor in their glucose control. And the number you should look for there is that if they check a finger stick at 1 to 2 hours after the start of a meal, the recommendation would be if they're in good control, the ADA would like to see it less than 180. So all of us, when we eat a meal, our glucose goes up because it's supposed to. But for those who don't have diabetes, it doesn't go up above about 145 because your insulin system in your body's working to keep it in check. But when people have diabetes, a target that, especially for older adults, that we're comfortable with would be less than 180, except on that table there's some adjustments for that, those glucose levels depending on the level of control you're looking for. Okay, so think about ways you might think, so what would you use for his diabetes, for his glucose control? So we talked about his goal would be at least less than 8%. One of the things I didn't mention is that lifestyle modification, so watching what you eat, increasing your movement or physical activity, that can also reduce A1C 1 to 2%. You don't get synergistic effects and you don't even get additive effects when you add multiple things together, but you do get a better than just one thing effect. But I also mentioned that metformin, it helps type 2 diabetes and it potentially has some cardiovascular protective effects. So we've got just a little room to improve our A1C goal to really have his diabetes more in control. And we've got 3 good ways to do it, to help him with what he eats, help him get moving more, and potentially metformin. The reason metformin is now on the guidelines for management of type 2 diabetes as starting it right away, we used to wait several months before we'd start a pill, is because changing what you eat and getting physically more active is not an easy thing to do. People have practiced their habits sometimes for many, many years, and so learning new habits can take a while. And so but we also know that leaving him with uncontrolled glucose could lead to damage if we wait a year or 2 for him to be able to have a lifestyle modification that changes his A1C. So that's why metformin we might start right away. So if I just switch to my next slide, here's some ideas that I had just to help kind of summarize our session here. I would actually strengthen his social support. He doesn't have a lot of support around him. He has 2 adult children who live out of state, and in the case I worked with, we're not very engaged. We're not aware at all what was going on in his health. I don't think he'd ever really had to share that with them. I don't think that he was keeping it from them. He just had always been kind of managing it on his own. He lives alone, and so just thinking about, is he able to cook meals? Is he able to procure food and have it, food available to cook? All of kind of that social support around making sure he can manage his diabetes is important. The A1C goal I would choose right now is less than 8%. And I would actually present that to Joseph as a really hopeful situation. Like, you're at 8.3, we're just going to try and get you to 8%. But if we start working on what you're eating and we get you moving a little bit and we start this medicine, we can really achieve that goal. And that's hopeful for him. I would improve his glucose while minimizing the risks of hypoglycemia. So that's why I think metformin would be a reasonable choice. In his case, I don't have his GFR here, but with this, I would have that checked, or I would calculate that or estimate that. I've got his serum creatinine and his weight and his age, and so there are some ways I could estimate that to make sure that he really should start the metformin, focusing on, does he have a GFR greater than 30 mils per minute? And to start it, most people are looking for more 45 to 60, because if they're like at 31, remember it's all an estimate, you're not wanting to start too low. I would encourage movement, and again, I would talk to him about what he likes doing. I usually say to people, what do you like to do? what are your hobbies? What do you like to do for activities? And I learn a lot, and especially when people have really surprised me. They'll say, like, if they're living in an assisted living, they say, well, I always liked gardening, so they let me prune the roses, and I go out in the garden and work in the garden. I'm like, that's a great activity. And so how many days a week are you doing that? Well, I just do it on weekends. Is there any way you could do that a couple more days a week? And all of a sudden, I've helped someone find an activity that they love doing that they can do where they're living without buying new tennis shoes and buying a sweatsuit or joining a gym. So kind of thinking about what they like to do. I have had people, including family members, say, well, I like to play cards and I like to read books, and I'm like, okay, so you like to sit around, and so then I teach just basic chair exercises and leg raises from a chair, or they can use soup cans, or sometimes water bottles are skinnier and easier to hold, but for mild weights, just to start doing a little bit more movement. Nutrition education. I'm a pharmacist, I'm not a dietitian, so I provide the really basics. I help people get acquainted with the power of the foods they're eating on raising their glucose. But when I feel they're ready, then I definitely refer them on to, or ask for a referral to, a dietitian, because a good dietitian, especially a dietitian who's certified as a diabetes educator, is just tremendously helpful to support patients in identifying the ways they can better eat. And then if they live in a care community, like a retirement community or care facility, finding out about the nutrition there is just a phone call away. And if you work there, you can find out what the menus are, and there's often the nutritional value that's spelled out for you. I think also there's an opportunity every time we see an older adult to reduce use of unnecessary meds. And so for me, and it's the pharmacist in me maybe, but when I see things like ranitidine and Tums, I'm thinking, okay, something's bothering his stomach, and what's going on? It says he has GERD, but why does he have GERD? Is it mechanical? Is he reclining right after eating? Is it a drug-induced problem? And I see that he's taking aspirin daily, and he's taking ibuprofen occasionally for pain. And so I guess I would tease that out more to see, is there a way we can manage the GERD without medications, or is he also having gastritis that he's treating with some of these medications that we can help resolve? So I would actually hone in on that to see if I could simplify his medication regimen a bit, because I just believe with anyone, but in particular older adults, anytime you can reduce that medication burden to make their life more simple around how to manage the really important things you're trying to manage, I think is important. And then there may be other ideas that you have. Yeah, in the classroom here, do you have an idea? Thank you. Yeah. Okay, so the input was the PHQ-9 score was 12. And so those of you familiar with that test know that above 10 is kind of a signal that you could have a moderate level of depression, or maybe even severe if it's higher. And if you're not familiar with that test, Google it, because you can actually download the test and the scoring tool and everything, and it's a validated tool that's very easy to use. But yeah, so that is a red flag on depression. And as you see, there's nothing really on board for him to help manage depression as far as his medications. And as far as I was aware, he wasn't receiving any cognitive behavioral therapy or any other counseling support. So he clearly has some risk factor going on that needs to be more thoroughly assessed here. And actually, just for depression treatment, some of the antidepressant drugs can actually help with neuropathic pain. So if he needed an antidepressant and I were to recommend one, I would probably try and find one that would cover both neuropathic pain as well as depression to help him out, like a duloxetine or something like that. Any other ideas that come to mind if you're at an external site, maybe chat amongst yourselves? Any ideas from the classroom?
I'm not sure if this relates, but a prior comment was talking about perhaps consider lower statin dose or different statin. Given simvastatin's notorious effect on glycemic control, is he on a statin? Yeah,
yes.
He is.
Yeah, and he's on what appears to be a higher dose, but it's not a high potency statin like an atorvastatin or a rosuvastatin. But yeah, so potentially kind of rethinking, does he need that statin? What's the benefit he's getting? You have objective measurements you can take if you lower the dose to see how much impact did lowering the dose have. So certainly backing off. In this patient's case, I don't recall that he had any symptoms like arthralgias or myalgias or any problems being on the statin, but it's a great consideration. Any other questions?
In general or about the case?
Either way, yeah. Because there I am.
Yeah. So there is a question that says, has there been a correlation with blood pressure fluctuation and levels of glucose?
Do you want me to repeat that?
No, you
Okay,
don't. When
so-
I've got a mic.
Okay, you've got a mic. Okay. Not that I know of. I'm not aware of data on a correlation between blood pressure fluctuations and glucose. Doesn't mean it doesn't happen, but I'm not aware of any data or guidance right now in diabetes around how to manage that. But I am a big believer that, and we didn't talk about hypertension, but if people are on antihypertensives, hypotension can be a concerning risk, especially a big risk for falls.
Mm-hmm.
And so I would approach hypertension management the same way I approach diabetes management, from thinking about minimizing the risk of hypotension and making sure that we're maintaining the antihypertensive effect we need, which in diabetes would be now to a systolic of less than 140 and a diastolic of less than 90. So if people are on tighter, more tightly controlled for their hypertension, and they start having blacking out when they're standing or dizziness on standing or anything like that, I would look at actually loosening up or relaxing their antihypertensive therapy to take them a little more towards that current comfort zone. There's a question right here. Okay.
My first is with the sulfonylureas, how they talked about they kind of open up
The door. Yeah.
do they kind of burn out the pancreas sooner then because they're
So the question is about sulfonylureas and their mechanism of action, and do they burn out the pancreas? And the answer is we don't totally know, but there were many years of research cautioning us that we don't want to burn out the pancreas. I think the reality we know is that, what does my colleague say? Don't flail failing beta cells. So, in other words, you can only squeeze so much, you can't squeeze water out of a rock. So if the pancreas is no longer making enough insulin, you can open those doors and squeeze on it all day long, and you're probably not going to burn it out. It's already burnt out. So again, if you start a sulfonylurea in someone and they don't get good glucose lowering with it, that would be a signal that maybe they're not making enough insulin anymore. And that actually might be a signal that they might benefit from insulin supplementation to even a small extent to help them out if their glucose is not well controlled.
would you wait the 3 months and check an A1C again to see if they're even if it's having an effect? Is that kind of how you would
Yeah, so the question is, would I wait 3 months and recheck an A1C? And I would not, because sulfonylureas, you can see their effect immediately. I would probably follow their glucoses over that week and have them get back to me with how they're doing on the new medicine. And if it looks like their glucose levels with their finger sticks have not changed at all, then I might rethink if that's going to be an effective treatment. I would first look at the dose, see if I might have undershot it on the dose since we start low in older adults. But if I bump the dose up and I'm still not seeing an effect, then I might consider, maybe they didn't have a lot of insulin in those little beta cells to push out.
Would you have them do checks on themselves if they're just like let's say they fill in metformin or you add it? Would you advise them?
So the question is on finger sticks and like metformin, and it's a good question. It's kind of a debate in the diabetes world. The studies don't show that if you're on metformin or certainly lifestyle changes, that finger stick checking is correlated with better outcomes. But for those of us who are diabetes educators and work with people, we see the power of the biofeedback of people seeing that I'm taking this medicine and my glucose levels are changing. So those studies are looking at populations, but when you work with someone one-on-one, it can be really good reinforcement, and it can also provide you feedback that the medicine's working. So I try and make it practical. With metformin, you're going to be looking at fasting glucose levels, and even a once-a-week check could give you feedback if that metformin dose is starting to kick in and if you need to increase the dose. And with a sulfonylurea, You could also look at fasting levels and just see, you could even, with the sulfonylurea, I might do it more frequently because of the risk of hypoglycemia. You don't have that risk with metformin. But just to make sure I also didn't overshoot the dose, so that if I saw it was going down too much, I'd know I need to back off a bit. Barb, did you have another question? Because I know we're done at 5:30, right?
Yeah. So this question asks, please address the side effect of diarrhea with metformin use and any advice to reduce this?
Yes, good question. So metformin, the primary side effect is gas, bloating, and diarrhea. Doesn't sound like a fun medicine to use. And I will be honest, I was in practice when it came out, and we started like big doses of metformin, and people were vomiting and having quick runs to the bathroom. And so the package insert actually says the starting dose is 500 milligrams twice a day, and that is the package insert starting dose. What we learned is that if you start the dose low, give it with a full solid meal, the largest meal of the day. And in older adults, I recommend, and so would the literature, that you start even with 250 milligrams, just once a day, given with the largest meal. There's no magic about dividing up metformin. It's divided so it can be divided amongst meals. And so people tend to think when something's ordered once a day, they should take it with breakfast when they get up. And with some people, that's with a cup of black coffee, which is kind of hard on the stomach. So I usually am very specific. I tell them, we're going to start at 250 milligrams, and there is now a 250 milligram dose. I want you to take this. I ask them, what's your largest meal of the day? And they tell me, and I say, okay, I want you to take it. I want you to eat that meal, then take this either right afterwards or eat half the meal, take it, and then finish the meal. So you get like a sandwich effect. And I reassure them that metformin is not hurting your stomach, but it does irritate the stomach sometimes. We start the dose low and then increase it just about every week as we realize, making sure they're tolerating it well. Then it tends to work fine. If you still have problems, the new extended release formulation, which isn't so new anymore, that actually has a lot less risk of having the GI side effects because it distributes it throughout the day. So that, and many insurance plans are covering that now better. So that would be the next step I would go. Yeah, really good question.
So with Joseph, I'm assuming, would you lower the hydrochlorothiazide dose?
So the hydrochlorothiazide dose is 25 milligrams, and the lisinopril and the hydrochlorothiazide are probably the two that are really helping the blood pressure. And the blood pressure is definitely below goal. I'd probably want to see more than one blood pressure before I'd change a dose. If that is the high for him and he tends to trend down, yeah, I might lower the dose. But if that is the low for him and he tends to trend up and I just caught him on a lower blood pressure day, then I probably would leave the dose alone. So I probably would want to see at least a little bit of a flow sheet of his blood pressures before I'd adjust the dose, or maybe a few visits worth. And you can also, a lot of pharmacies and fire stations have blood pressure checking, and so even having a patient when they're in their pharmacy picking up their refills, check their blood pressure and have it noted or write it down. There's usually a report they can print out to help with more of that trend is helpful. Yeah, good question.
So what would you recommend for management of hypoglycemia in elderly living alone? Call 911 first, then test, test, or treat? Which treatment if living alone? Injection versus oral tabs, gel versus juice?
So a management of hypoglycemia.
Yes.
Yeah. So what I would recommend, and we teach the rule of 15, if somebody has a low blood sugar defined as technically less than 70, but for older adults I say less than 80, since their sensing of that might be delayed, they should take 15 grams of a fast-acting glucose supply. Fast-acting glucose is something that's not slowed down by fat, so not candy, like chocolate has fat in it. Skittles, it's like 14 Skittles. Look at packages. You can actually have some fun with those little Halloween packages of candy to look. 4 ounces of orange juice, 8 ounces of skim milk. There's several approaches, and if people can use household foods, that's fine. When people are out and about, a lot of the people I work with keep like a can of apple juice or a box of apple juice in their glove compartment. But an easier tool is a glucose tablet pack, because you can cart those around and they store well. Sometimes apple juice expires, so they have to make sure it's in date. If glucose tablets are used, the big teaching point is make sure patients realize one tablet is only 3 or 4 grams of glucose. So they need to have often 3 or 4 tablets depending on the dose. And so it's like 4 of the 4-gram glucose tablets would be 16 grams of carbohydrate. That should raise their blood glucose about 30 to 50 points. And as far as whether to call 911 or treat, if they're conscious and alert and they realize I'm just shaking, I'm going low, I would have them treat first, then check, so they know where they're at. It's not going to change instantaneously, but getting the treatment in first is way more important than delaying the treatment to get out your testing supplies. So have them treat first, then check. If they're feeling confused, and if they're cognitively aware that they're going low, and they're starting to feel like, I think I need help, they should always call 911 if they need it. If they're living alone, it is a tough thing because also Medicare does not cover well. We don't have good sensing devices right now. There are some really loud blast alarms that can help with sensing. And the Gluco Watch, when it was available, actually it sounded an alarm, but it's not a very accessible device anymore. So they are working on some devices that can help people who live alone be alerted if they've gone low. But Medicare, as far as glucose sensors and things, that's not something really covered. So it's a little bit trickier. And so with regard to if they become unconscious, the ideal for someone living alone is that can catch it before that happens. So checking their glucose before bedtime if they live alone to make sure they have enough in their system to get them through the night. And then, which would be like at least in the 100 to 140 range. And then if they're going to be around relatives or friends, if they can train other people on how to help them, that's really important. And people who are using insulin should have a prescription for glucagon, which is the counter-regulatory hormone, which will raise glucose levels. But that is only to be used if people are unconscious. So the patient may need to learn how it should be administered, but they're not the one who's going to be administering it. So for those who are pharmacists in the audience, I really recommend patients bring in the family member or coworker or whoever might be the person that has to give it so they can get trained on it, because the pharmacists in the audience know it's a little bit of a funky apparatus. There's actually a glucagon pen that has just been approved, which will be easier to use.
Helpful.
Great questions. And if you use glucagon, put someone in the rescue position because they may vomit from the glucagon. So just the last little parting advice.
I like
there.
the rescue
Yeah.
position.
Thank you so much.
Thank you.
Thank you.